Yes.
Yes.
So, Augusto, I will leave the floor to you now to begin.
Okay. So, good afternoon to everybody. First of all, I'd like to say thank you very much for your participation to this joint webinar between IFNGO and the World Federation Against Drugs. And I'd like to say to thank you, Regina, for this cooperation for the first time we cooperate together to host this. So thank you very much. Before I start, and thank you also to Karen and to Karen Peters and to all the other speakers for accepting our invitation. And before we start, I'd like just to introduce what is IFNGO for those members that they don't know what is it. It's the International Federation of Non-Government Organizations for the Prevention of Drug and Substance Abuse. IFNGO was launched in 1981 and comprising non-government organizations all over the world engaged in anti-drug and substance abuse activities. Currently, IFNGO have a reduce of members, so we only have in this moment 17 members, countries involving 22 organizations. So we hope with the time to grow up much more. Since 2016, IFNGO has been more focused in Asia, organizing conference Macau, Beijing, Jakarta, Singapore in 2022, as well workshops in cooperation with the ONUDC regional office in Bangkok with Karen Peters, and which we are focused in capacity building and prevention, etc. This event happened due to the good relationship between the IFNGO and the WFAD. Both organizations have many registered members in Asia, and we thought it could be very important and cooperate together to bring together many Asian organizations as possible and discuss important drug issues matters. We start with the recovery, and as we think it's an important subject in Asia, often by not so good reasons, and due to the lack of treatment quality or drug compulsory treatment centers, so often is very have a negative impact in the community in our community. But we also want to show that also good things happen in Asia, good examples, and we hope this workshop can reflect some of the good examples happen in Asia. Also, as you know, currently the Vienna GOC there's a group we call the Asian Working Group, which I'm involved. We are focusing in building in Asia consensus on Asia drug matters, and not only we want to show the best practice happen and results in Asia, but also we want to show the challenge and that we have ahead, and also situations in Asia that it will be good to change and to improve. And for that, we want to build a consensus to present next year at the CND. So therefore, I applied to the participation of all the members of Asian associations in the next side event at the CND in the 2 weeks ahead. And that's it. Thank you very much. I'll pass now to my colleague Regina, that she'll be the one that will handle the rest of the webinar. Thank you very much for your attention.
Thank you, Augusto. And much like you say, it's our sincere pleasure to be here today with you and co-organize this webinar with the IFNGO. Apologies, I was hearing my voice double time, so I just had to mute a colleague. Sorry for that. Like I said, and like you said as well, Augusto, we are very pleased to be co-organizing this event together with the IFNGO. And I believe it shows that proof of our global community and the fact that we can join in so many participants from different parts of the world. And I'm happy to say that we have over 200 registrations, mainly from different parts in Asia. But we also have some registrations from Europe, Africa, and North America. So hopefully you will all join us today and hear about these best practices in the Asian region. I'll do the same as Augusto and just say something short about WFAD for those of you who do not know about us. We're a multilateral community or an umbrella organization of different organizations and individuals with over 300 members in almost 60 countries. Our joint aim is to strengthen prevention, increase access to treatment, and to promote recovery. And we've had a previous webinar series on recovery, which can be found on our website and watched on Vimeo. And we hope that this Asian-focused webinar will become a series as well. So if you would like to become members of our global network, you're most welcome to visit our website and apply for membership with the WFAD, as well as with the IFNGO. We have a terrific webinar ahead of us today, and I would like to warmly welcome all of our participants and our terrific speakers who have taken the time to be here with us today. I thought I'd just say some practicalities. You're welcome to write hello in the chat. I see that some of you are already doing so. Maybe say where you're from, which organization, so that we can get to know each other even though we don't see each other's faces. If you'd like to ask questions or make comments, please use the Q&A function on the bottom of your screen, and my colleague Kristen and I will make sure to read all of your comments and questions. Each speaker will have about 15 minutes to present, and then depending on the time, we will make sure to have 1 or 2 questions after each speaker, so that it's more interactive. And then we'll have a good amount of time at the end of the event as well to ask any questions that may be left. So to leave as much time as possible for the speakers and the discussions, I will just briefly introduce each speaker. We have the full bios of everybody on the website. So if you want to learn more about a particular person, you can visit our website and read more about them. So without further ado, I am very pleased to welcome our keynote speaker, Karen Peters. Karen is the Regional Drugs and Health Program Officer of UNODC of the Southeast Asia and Pacific. Her work focuses on providing technical assistance on drug use prevention, drug dependence treatment, and HIV prevention for people who use drugs and people in prisons. We are very happy to have you today, Karen, and the floor is yours.
Thank you so much. Unmute myself. Thanks so much, Regina, and good afternoon, everyone, and good morning to those that are still in Europe. It's a pleasure to be able to present to you today, and also, of course, a pleasure to see so many friends from across the region and globally. I'm going to provide an overview of international standards around drug treatment, and specifically talk about that in the context of our the drug treatment landscape within Southeast Asia. Because I don't have a lot of time, I'd kind of, and give an overview also on what are some of the points that we should be looking out for when we are designing treatment systems. Regina, you will tell me if my internet goes crazy. I've tried to be the most stable, but let's see. Is it possible to put that onto presentation mode? I think it's in the view function and it should be full screen. There we go. Thank you. I'm going to focus specifically on these UNODC publications, and you'll understand why. The first one is quite obvious. This is a session on drug treatment. So it is the international standards for the treatment of drug use disorders. But the other two are a little bit more important and specific for our region of Southeast Asia in relation to the drug use situation. We go to the next slide. I don't think it's a secret, and I think that it's generally a well understood topic that prisons in our region are impacted hugely by levels of overcrowding. Occupancy levels in some countries, for example, the Philippines, are excessively high. This is data taken from the World Prison Brief, and this was, what I was collected during the COVID-19 situation. The numbers might have dropped, and you'll see a table on the right that shows some of the planned or actual prisoner release figures from countries in the region. Not all of the countries planned to release prisoners to cope with the overcrowding situation and infection control within prisons, but some of them have had at the time promised to, and so there was a general understanding that the situation in prisons is quite intense in terms of occupancy levels. The reason this is important is because a vast majority, up to 80% in some instances, of people that are imprisoned in our region are there for drug-related offenses. Okay, and that ranges from a range of offenses from use to possession, to drug trafficking and distribution, and so on. So these numbers are fueled by the drug issue within our region. If we can move to the next slide. But what does that mean for us? We speak a lot about alternatives to imprisonment as UNODC. And in relation to these alternatives, we promote that countries should consider, for example, not imprisoning people for low-level offenses related to their use or possession of narcotic substances. And so the alternatives in our understanding and what we support governments to develop is to develop and support drug treatment as an alternative. But if we're going to be promoting drug treatment as an alternative, we also need to ensure that the treatment that is currently available in the countries are therefore up to standard. So these are the first document that I shared with you, which is the International Standards on the Treatment of Drug Use Disorders. And there are 7 of them. And the first one speaks about treatment needing to be available, accessible, attractive, and appropriate. This speaks specifically to the treatment services themselves. Are they available to people that would like to access them? Are they accessible, which means, for example, looking at issues around costing or affordability for people that would like to engage or would like to enter into drug treatment? Are they attractive? Essentially, are they client-centered? Right, so are the treatment services that we are developing or offering, are they client-centered? And are they appropriate? Okay, so if somebody comes in with a stab wound to an emergency room, we don't decide to, do an X-ray on them and send them for physiotherapy. We deal with the issue as it is appropriate for the illness or the condition that that person has. And in the same way, drug treatment services need to be appropriate for the condition that the person is experiencing. The second principle is around ensuring ethical standards of care in treatment services, and this is a very important one because it also speaks to the rights of individuals, which are humans, human rights, to access drug treatment services in a free and non-stigmatizing way. Okay, so part of the basic human rights is that every individual should have access to health services. And we believe that drug treatment, of course, falls within the realm of health services. The next one is the reason I'm explaining that is particularly speaking to principle number 3, which is promoting treatment of drug use disorders by effective coordination between criminal justice system and health and social services. Okay, we understand that drug dependence or drug use disorders are multifactorial health concerns or health disorders. And what does that mean? It means that there are very, very many reasons that people develop a drug use disorder or dependence on narcotic substances. And so because there are varying reasons that people would develop a dependence, there should also be varying solutions for addressing the issue of drug dependence. Okay, and this involves not just treatment as a health modality, but also treatment within, what social services would we need to support the person that is engaged in or in need of drug treatment. Okay. This also speaks to the coordination between criminal justice systems. Okay, like I mentioned earlier around the issue of prison overcrowding, one of the ways in which to address the issue of prison overcrowding is to assess whether the person that has committed a low-level offense can be referred to outpatients or outpatients or community-based treatment services, okay, as opposed to being imprisoned within the criminal justice system. And this can only happen if there is effective coordination between criminal justice, health, and social services. That treatment must be based in scientific evidence and respond to specific needs of individuals with drug use disorders. This is another huge issue within our region, that a lot of people are claiming to be offering drug treatment services, and the services that they are offering are not evidence-based. And this leads to a multitude of huge concerns. Firstly, human rights concerns to pose something as drug treatment while it is not actually a known treatment modality, can have sort of negative consequences on the person's physical health. But also it has very negative consequences to positive treatment outcomes. Okay, if a person is undergoing treatment for drug use disorder, and that treatment itself has not been proven to be effective in terms of being researched and scientifically studied, and the person, for example, defaults on that treatment that is unscientific, that can have negative consequences to the person continuing to seek drug treatment in the future should they relapse, or to adhering to any treatment protocol in the future. Okay, so this has negative consequences for several reasons. We can go to the next slide. That treatment should also respond to the needs of specific populations, and the standards outline what these populations are. For example, pregnant women, they need specific care in terms of drug treatment should they wish to enter into a treatment regime. Adolescents or children that might be, you know, have drug use disorders, people living with HIV, people with disabilities. These are the, for example, some of the types of special populations that the standards talk about. And so we need to ensure that if we're offering services at the general population level, that these are adequately encompassing these population groups. That treatment should be ensuring good clinical governance of the services and the programs for drug use disorder. This, I think, also speaks to, you know, the ethics and the human rights standards. We should be offering treatment that is of a high standard and that adheres to clinical governance sort of procedures and protocol. That treatment policies, services, and procedures should support an integrated treatment approach with linkages to complementary services, and they must be constantly monitored and evaluated. That is indeed essential. One treatment facility or one treatment service package cannot necessarily provide all of the services that a person with a drug use disorder might need. And so it is essential, therefore, to have correct linkages in the community, including, for example, linkages to harm reduction services, should the person decide that they will not enter treatment now, but they would like to prevent themselves from contracting other communicable illnesses. Can we move to the next slide? This I had to mention because it's part of the joint advocacy in our region, and it is something that we have been speaking with governments about for a number of years now, is the concerns around compulsory drug detention and rehabilitation centers. And for all of the reasons that I'd mentioned earlier, these centers pose a problem to communities in our region. And these are the agencies that support that. And this statement was, the most recent one was issued last year in the context of COVID-19, but the advocacy around closing compulsory treatment centers has been ongoing for a number of years. Next slide, please. So why do I highlight the methamphetamine publications? Particularly in our region, methamphetamine is a growing concern. We see seizures that are year on year breaking records with the amount that is coming from this region. At the same time, we've seen countries reporting a reduction in opium poppy cultivation, for example, in Lao PDR and in Myanmar, two of the opium producing countries in our region. And if we move to the next slide, we'll also see that drug treatment admissions in countries have changed following the same pattern, right? So whereas people were being initiated into drug treatment for opioid substances, now they are far exceeding, the methamphetamine treatment admissions are far exceeding any other. Can we move to the next slide, please? While we know that there are a lot of people that use drugs, we also understand that not all of the people that use drugs enter into treatment or get in contact with treatment services. They do, however, have the opportunity and should have the opportunity to be in access stimulant drug HIV prevention services. And UNODC will have worked with WHO and UNAIDS to come up with this comprehensive list of HIV harm reduction services for people who are using stimulant drugs. It varies a little bit to the other comprehensive list of services for people who are injecting drugs, because it's not just about injecting drug use now. We understand that methamphetamine users come from a range of different types, modes of use, and that can be, thanks Regina, and that can be injecting use, and it can also be oral use of methamphetamines or amphetamine type stimulants, and a varying range, smoking, so on and so forth. The one thing I just want to highlight about this comprehensive package before we move on is number 5. Okay, so evidence-based drug dependence treatment and behavioral therapies are part of the comprehensive package of harm reduction services for stimulant drug users. Okay, they're not separate too. If we can move on to the next slide. Also, just to highlight that there is this discussion paper. Like I said, we don't have a lot of time in 15 minutes to get through all of the details, but I would love you to please go and find these documents on our website. They're not hard to search for. And this discussion paper I particularly love because it outlines what are the types of treatment that are there for people who use stimulant drugs. And it shows the promising practices, not yet best practices and not yet the evidence in some instances, of course, because they're small case studies, but it shows what some of the promising practices around the two types of treatment. And so if you are curious around this, maybe you see a lot of your clients are entering and need support for methamphetamine or amphetamine type stimulant drugs, please do find out what some of the suggested therapies are. If we go to the next slide. Okay, just to quickly understand, when we're talking about drug treatment, we're not only talking about residential treatment. We promote at UNODC community-based treatment as an alternative to residential treatment, which is seen generally as the only type of treatment that is effective. We're saying that it's not, because the vast majority of individuals that use drugs never or do not have a drug use disorder. So if we are offering the services that will engage people into accessing the health system, then we need to also have the services that are not only tailored towards long stay residential facilities. And in fact, in terms of a health system, we promote that the vast majority of health services are offered at an outpatient level and low threshold and are accessible to people at the community level, what we call community-based treatment. If we just move on, I will just highlight this document. I'm not going to go through the principles of community-based treatment, but there's a really great one that was developed specifically for our region, and it's looking specifically at the health systems within our region. And so it speaks to drug treatment that is designed, for what is available here in Southeast Asia. And that is all. Thank you. I think that's the second to last slide.
Thank you very much, Karen. I thought that we could even just take the time to ask a question. We have received two questions in the Q&A box, one of which is asking if the presentations will be available to participants. And I am sure that if all speakers agree, we will of course share these presentations after the webinar. The other question is directed towards you, Karen. I'm not sure if you can see it, but I'll read it out. It says, what can we do to develop drug treatment and harm reduction programs in our psychiatric hospitals and prisons, which does not have the capability to treat drug users? This is for us in developing countries like Fiji.
That is an excellent question. And the brief answer is for me to direct you towards the community-based treatment guidance document that I outlined, which I can actually ask Regina to share the links to these documents with you, Regina and Cressida. So you will definitely be able to find out the community-based treatment guidance document exactly tells you what to do in instances where you do not necessarily have trained, skilled addiction treatment, staff or personnel. In some instances, there's not much you can do, especially if it relates to prescribing medication or sort of psychiatric therapies that might be required by the client. But in a lot of the cases, there are very low threshold services that you can make available. The other components that I've mentioned around the community-based treatment guidance document is a training that UNODC offer to countries in this region. And definitely it can be arranged for Fiji. And this training is also around building the capacity of outreach workers and community workers to manage and deal with treatment services that are low threshold, outpatient, and in the community. Okay.
Thank you very much, Karen. For those answers and for your fantastic presentation. And much like you said, we welcome everybody to go to these international standards that Karen have so fantastically presented. And they are very good use. They're very vast, and just like you say, you can even use them as somewhat of a dictionary at times, or a dictionary, but a glossary, so to speak. Thank you so much, Karen, for being here and for sharing this presentation with us. I see that we have a raised hand, or we did have a raised hand, but now it is gone. So if you'd like to ask your question, please write it in the Q&A, and then we'll try to figure out the function of raising hands for our next speaker. I will continue and present our next speaker. Let's see if Asia is with us today. We can highlight her as well. Yes, here. Hi, Asia.
Hi,
Lovely to see you. And we are happy to have you here. This is Asia Ashraf. She is the founder of Peace In, a house of peace and tranquility for mental health and substance use disorder treatment, rehabilitation, and prevention in Pakistan. Asia is also a special advisor to the board of WFAD. We are very pleased to have you with us today, Asia. The floor is yours.
Thank you very much, Regina. Thank you very much. Good afternoon, ladies and gentlemen, and it's my pleasure to be among you all. I would start my presentation with a very brief introduction of me. I am Asia Ashraf, working in the field of drug addiction treatment and rehabilitation from last 18 years. I am Humphrey alumna, internationally certified addiction professional, and a national trainer of UNODC and Colombo Plan. As Regina mentioned, that I am a special advisor to the board of WFAD for Asia. In addition to that, I am a core member of Gender Working Group WFAD and Drug Policy Futures. Today, I am going to present about, Regina, are you going to share my screen?
I believe.
Should I do it?
It's whichever you prefer. We can share it, or if you would like to share.
You can share, I think.
Okay. Okay, you can continue, Asia, and I will just open it.
Yeah, because before I start, today I am going to present a very, like a kind of a sum of a conclusion of a whole 18-year services, like what are the best treatment and recovery practices in Asia. I will speak about with reference to my country, Pakistan. So are we able to open, Regina? Or should let me try?
I'm just opening it now. Apologies. It's a little bit slow, my computer today. Let's see. There you go.
Yeah. It's just, I think it says like,
Can you see it, Asia?
no, yeah. Let me see. Sorry. Yes. Can we go to the, yes. Thank you very much. So today, as I spoke, I will be presenting about best treatment and recovery interventions in Asia. So I will start with the map of my country. Many of you may not be aware where Pakistan is located, or mostly you might be aware. Pakistan is located in Southeast Asia. You can see India, Iran, Afghanistan, and China. They are our neighbors. Neighborhood with Afghanistan is a bit critical. Afghanistan is basically a landlocked state, and we share a very long porous border with Afghanistan. And next slide. And that is very much important. We all know that unfortunately Afghanistan is world's largest illicit drug producer. UNODC estimates that 90% of illicit drugs, they are produced in Afghanistan, and 40 to 45% of illicit drugs, both cannabis and opium, they are transited through Pakistan. So Pakistan is both a transit corridor as well as a consumer of illicit Afghanistan drugs. You can see that this is the map. It shows how the drugs, they are transited to different parts of the Pakistan to the rest of the world. Next. As per a UNODC report in 2013, in Pakistan, there were 6.7 million, around 7 million illicit drug users. They were the people who used any type of illicit drugs, or at least one in their life, and their age range was between 15 and 16 years of age. And among those 7.7 million drug users, there were 4.25 million with substance use disorder. When I say with substance use disorder, it means that they require some sort of a structured treatment. And among those 7 million, there are 5.2 million, around 78%, they were men, and around 1.5 million or 22%, they were found to be women. And we all know that female drug abuse is kind of underreported, understudied, unlike the male who congregate together, and it is easy for any agency to get data about them. But when we come to the female, it is more an isolated activity. So there were more hidden population that was not covered in that report of UNODC in 2013. Sorry. Next. The range of start of initiation of drugs, it was about 15 years. Like in that report, the people all they started at age of 15. Now the age has decreased up to 9 years. Sorry. The commonly used drug was like cannabis. 75% of the heroin users, they reported that their first drug of choice, the first drug with which they started, it was cannabis. And but now the number has been increased, like, and there were around 4 million cannabis users nationwide in the UNODC 2013 report. I'm not talking about like how the figures are now, because now the cocaine or ice, it is getting a real pandemic in my country. There were 2.7 million opiate users. When I say opiate users, they were using opium, heroin, and synthetic opioids. And just to give you a, can you have another next slide, Rugina? Just to give you a how the drug situation is escalating or worsening in my country. If you just see this chart, and if I just focus on people with injecting drug use, in year 2000, their number was 75,000. But in year 2012, their number has risen up to 430,000. Almost it is like a 5-fold increase. So this a very short slide can give you a glimpse of how actually the substance abuse is increasing in my country, Pakistan. Next. And if I and how is the treatment, overall treatment capacity in the country? As per UNODC report, there were around 96 drug treatment and rehabilitation centers. It includes all the government, private, NGOs, or even in this kind of just detox centers. Only in a like 30,000 people in a year could get treatment. In UNODC report, like 70% of the people who were using heroin, they mentioned that they really wanted treatment, but they couldn't get treatment. Either it was not available or it was too costly. And all the treatment facilities, they were male oriented. As I mentioned earlier, the female drug abuse, like in my country, it is not, it is underreported, understudied, and female, they are reluctant to seek help because of the socio-cultural constraints, because of the religious constraints, because of the fear of losing marriage, children, and there are dearth of expertise. So there were no female specific services at that time in the UNODC report. We can move to the next one. No, I'll just focus on like, after giving you a brief background of how the drug and treatment situation is in my country, I'll be focusing on a little background of treatment and recovery. It's just a vast topic. I tried to sum up whatever could be presented in 15 minutes. So the treatment and recovery services, like if I say like in many other parts of the world, in my country, there are treatment facilities which we can say that they are highly substandard. When I say substandard, it means that they are more a kind of lockups, still practicing cold turkey, no humane detoxification, no medical assisted treatment. They're more like prison cells, and there is dearth of expertise, like they don't have trained doctors, psychiatrists, or counselors, etc. But when I say that there are treatment services which are really providing evidence-based services, and before I speak about them, I would really like to mention the role of UNODC, Colombo Plan, and ISAP in my country. What they have, these agencies, what they have done is that they started in 2012. It's a kind of a training of addiction professionals in Pakistan. So there were like, it was a huge step in my country, and it is still ongoing. There are a lot of people, like around more than 100 people, they are still getting training. So what they did is that they started training and credentialing of addiction professionals in universal treatment curriculums. There are basically 8 curriculums. Like they have the curriculums related to physiology and pharmacology of addictions, substance use disorder, and like their curriculums related to screening, assessment, and detoxification, rehabilitation, recovery, case management, basic counseling skills, and like and ethics of addiction professionals, and like it is like a whole package. And there is an also additional curriculum which is called 4A, which is more related to relapse prevention training. So both UNODC and Colombo Plan and ISAP, they have links, they have resources. As I mentioned, I am a national trainer for the UNODC and Colombo Plan. So they give training. I am sure they're giving trainings in other parts of the world as well. So after the training, they provide a 4 level of certification. That is internationally certified addiction professional from level 1 and up to the level 4. So what this step has done, it has created more a pool of trained, knowledgeable, and learned professionals. So when there is capacity of professionals in the field. So it is directly affecting the people who are getting services, like people with substance use disorder and their families. So this step has it has played a great role. So can we move to the next slide, Regina? So I would be focusing on the shift or the change, a positive change, which I have seen in a couple of years in my country. So after this training and and more people are going into the field, because initially the field was so stigmatized that the female, they were reluctant to work in the field, and there were very few professionals. So now there is a shift from a confrontational approaches towards motivational approaches. When I say confrontational approaches, I mean that addiction was substance use disorder. They were more viewed as a character flaw or moral sin. It was assumed more that the people with substance use disorder, they are in some sort of a denial, and they require a strong confrontation to break their denial. So the more persons or the people suffering from SUD, they were brought into the treatment centers by the crisis intervention, like through the family forcefully bringing them, or to the police, or to the a third agency. So it was a more confrontation in which they were not very willing to quit and start a new life. So from that shift, there is a change towards the motivational approaches. Now the organization or treatment facilities, they are working more on how we can create an insight, how we can using studies of change model or motivational enhancement therapies, like especially motivational interviewing is used to guide the patient, like if it how it is a disease and why the change is important. So this is the funds very strong shift. Second is understanding and treatment of substance use disorder is more viewed as a disease. I wouldn't say that there is no stigma. It is highly stigmatized still, a disease in my country. And the stigma is not associated with just the use of substance. It is more getting associated with for the people who are into the treatment, like, oh, they are in the residential facility or they are getting treatment. Even for those who are able to get treatment, for them the stigma is even higher. But still it is viewed as a now as more as a brain disease which requires a treatment. And thirdly, there is a more humane detoxification and more supervised. The patients, they are just not left to suffer in the pain. So there is a people are working like to provide them supervised, well managed detoxification and managing specifically their withdrawals. As Rugina knows, I was working with Sunny Trust from last 17 years. I had served them, and I found that there was a very integrated care of integrated system of care, where all the professionals like doctors, psychiatrists, psychologists, counselors, they were just working under one roof. So the integrated system of care with all the professionals working together in joint collaboration, it has proven to be a really a very well practice in Asia. Can we move to the next slide? Please let me know if my speed is fast or I'm not audible. So initially there was more focus on just detoxification, just providing now the treatment facilities, they have realized that detoxification is just the first step. It is the first step. It is not the end. It is not the whole treatment. So the focus is shifting on from just detoxification to a complete biopsychosocial and spiritual rehabilitation. So it is very much important, like staying in a residential treatment for a minimum of at least 90 days, and then following up complete comprehensive methodology where the focus is on biopsychosocial and spiritual rehabilitation. It has really given a good recovery rate I have seen in my country. And the focus is more on using evidence-based treatment approaches, like from just advice, lecture, confrontation. Now, as I mentioned that we are having more trained professionals, so they are using more evidence-based practices. We all being in the field are very well aware of cognitive behavior therapy, in which there is focus on more thought restructuring or cognitive restructuring. There are motivational enhancement therapies in which their focus is more on motivation and stages of change, and contingency management therapy in which principle of reinforcement and rewards are used, and family therapy. Very important. I have seen that when family, service providers, and the clients, they work in a triangular effort, the results are far more better, more with less relapse ratio in my country. And we have also started a case management, because not only a single treatment facility can cover all the needs which patient requires. So there is the case managers, they ensure that the clients, they get all the services they need, like if they need treatment of comorbid or co-occurring disorders, if there are family issues, if there are any job issues, or if they need a long-term treatment for hepatitis B, C, and some everything. So the case managers ensure that the client get all the services within the facility, or sorry.
We have just 1 more minute, Asya.
Oh, okay. So the case manage, I'll try to wind up as early as possible. So the case management ensures that the clients get all the services within the facility or by linking them with other organizations. And most important, the focus is now on a continuum of care. So it is not just within the treatment, it is more on the aftercare services, like follow-up. That is kind of it has to be continued once they're out. Can we move to the next slide? I think I have lost 1 minute in the moment. Are you able to open? And now the focus is more on a recovery oriented system of care. We can move to the next slide. Because we all know that recovery is not a destination. It is a process. It is a process of change. The treatment providers, families, and clients, they know that they will go through a process of change and they will attain a stage of health and wellness. And it is about living a balanced life, and it is more on striving full potential of the people who are in recovery. Can we move to the next slide? I would just like to highlight one important aspect which I have seen in my country, that there was some sort of a gap in the system. Like if the client, they get all the services within the facility, and when they go out, so there was like a gap in sort of like from a very supervised care to the mainstream society. So the clients, they were suffering from a lot of the problems, like with the family, or the follow-up or aftercare was addressing, but still we felt that there should be something more than that. So we created some sort of a first recovery club in Pakistan, which is open, safe, free, friendly space over where the clients, with the program staff and with the peers, they can come anytime and they discuss their problems, which are they're really facing at hand, over a cup of tea and coffee. And it served as it's like a great success. So I would conclude my presentation with the last slide. That is the organization which work with other community, and which have known that it is very much important to involve parents, students, family, or other stakeholders of the community. They are really doing well. They are able to find more resources which can actually strengthen, support, and promote recovery. With this, I would conclude my presentation. Thank you very much, Regina, and thank you very much.
Thank you very much, Asya, for this fantastic presentation. We went a little bit over time, but I reckon we will do one
Sorry.
question and then we will save the other questions for our Q&A session at the end. I'll take the first one and do them as they came in. And it's from Sharon T. And Sharon says, "Hi, Asia. Thank you for your presentation. Are there any directive, not confrontational approaches that you have seen to be effective?"
Sorry?
Are there any directive and not non-confrontational approaches that you have seen to be effective?
As I mentioned in my presentation, that motivational approaches in which we are using motivational interviewing, motivational enhancement therapies, they are, and we are using, we are focusing more on the training up professionals on to be the, you know, a Rogerian school of thought, providing unconditional respect, regard to the clients. They are really working well.
Thank you very much, Asia, and thank you for being here with us today. As for the questions that we don't have time to answer as we go, we'll take time for those at the end. And if there are any unanswered questions when we finish, we'll ask our speakers to kindly send those answers.
My apologies for the overshoot of time.
No, it's not on you. It was it's often the case. We're very happy to hear from you and that you were able to hold the whole presentation. So thank you, Asia.
Thank you, Regina.
Our next speaker is Mr. Iqbal Masood. Mr. Iqbal is the director of Dhaka Asania Mission in Bangladesh and currently heads up the health and wash sector, overseeing 21 health and wash projects and 6 institutions, including 4 drug addiction treatment and rehabilitation centers for males and 1 similar center for females. We're very pleased to have you here with us today, Mr. Iqbal. The floor is yours.
Okay, are you hearing me?
Yes.
Thank you, Regina, for excellent consultation meeting. And thanks to World Drug Federation and also IFNGO for arranging this type of meeting and experience sharing event for the practitioner and the participants also. I will focus my presentation on our own experiences because we are implementing a drug prevention and treatment program since 1990, at least 30 years. We are working in Bangladesh. So my presentation first is a geographical location in Bangladesh. It's too vulnerable. One side is Golden Crescent. Earlier presentation and even Odyssey shows that Afghanistan is world largest opium producing country, and also Golden Triangle in Myanmar. We have direct border with Myanmar, Burma. So basically the drugs came from the 2 region, Golden Crescent and Golden Triangle. And Bangladesh is not a drug producing country. A little bit country liquor Bangladesh produce and also cannabis, but few. But maximum drug users is increasing is amphetamine type of drugs is come from Myanmar, Thailand, and that region. And this is the Bangladesh map. Basically, I mentioned the Bangladesh not is a drug producing country. Bangladesh used as a transit country and from the different way from the seaport, airport, and land port also to come through Pakistan, India to Bangladesh, and Bangladesh to Europe and America and other Asian country also. This transit from the Bangladesh. And basically, amphetamine type of drugs come from Myanmar and Thailand, and we have direct border with the Myanmar. So Bangladesh context, exact number of drug users are not been established. Still, we don't know how many drug users in Bangladesh, but some informal study and assumption mentions that 6 million drug users in Bangladesh, and male users in more than female users in Bangladesh. And early childhood is the most vulnerable ages in Bangladesh because we have seen the children and adolescents are taking drugs, and they are the most vulnerable in the context of Bangladesh. And all segments of the society are being affected in Bangladesh. Once time, there are lower segment of people and higher segment of people use drugs. But now all segment of people, middle class, higher middle class, and lower middle class people using drugs. We can't define the segments of the society. And last year, we conducted a national level study, and we have seen our study found 49% drug dependent at least once a time arrests due to drug related cases, and 92% drug dependent did not receive any treatment inside the prisons. So that Dhaka Hasina Mission is implementing prison intervention with the support of German government and also Prison Directorate and Home Ministry. We are providing counseling support and vocational training support inside the prison, especially for the convicted prisoner. And after release, we refer to the rehabilitation center, also job placement and other vocational training and rehabilitation services we are providing. And now I'm coming to Dhaka Hasina Mission. Dhaka Hasina Mission is the oldest organization in Bangladesh, established in 1958, more than 65 years ago, founded by Khan Bahadur Hassanullah. He was the educationist under the British government during the British rule in our Indian continent. We have legal status with Social Welfare Department and NGO Affairs Bureau and others, Narcotics Department. And DAM is enjoying consultative status with UNECOSO and also consultative status with UNESCO. We have 2 offices outside Bangladesh, one in UK and one in USA, and we have a representative in Canada and Australia. At present, Dhaka Hasina Mission implementing 52 donor-funded projects. Our main donor is European Union, USAID, British government, German government, etc. And also our organization established 29 institutions like university, cancer hospital, boutique shop, IT institute, college, school like this. And out of 29, we are running 4 drug treatment and rehabilitation center in Bangladesh. And more than 6,000 staff working with Dhaka Hasina Mission. And we have major 3 areas we are working: education, economic development, and health and water sector. And rights and governance is a cross-cutting, and climate change is a cross-cutting issue. Our SOD intervention, basically this is our intervention established in DAM. We have established 4 centers, and all centers is our own building and own campus. Is a big area we purchased and established in building and in the center. It's not a building or on 4 or 5 rooms or apartment. It's their own campus. The client can use that campus and outdoor games and other recreational activities. We have a wings, research and advocacy. We are experienced on policy advocacy. Still, we are reviewing the national laws and also drug treatment law. I am the member of the law committee formed by Home Ministry. We are organizing capacity building support to our staff, not only our staff, our organization also a education provider of the Colombo plan. So we are providing UTC and children living drug-free children curriculum in Bangladesh. And we have also prevention activities in the community level, education institute level. We have vocational training center, 3 vocational training center we are running at present with the approval of technical board of the Bangladesh government. And we have good networking in Bangladesh and also the outside Bangladesh and collaborative partner in the community. And Dhaka Hasina Mission working with the Songjog. Songjog is a national network for the drug treatment centers network in Bangladesh, and at present 70 drug treatment center member of this network. I am the president of the Songjog at present, and Dhaka Hasina Mission is the secretariat of this network. So we are providing capacity building support to the other drug treatment center through a Colombo plan, UTC and children curricula. Now I'm coming to our treatment process. We learned many things from Colombo Plan and UNODC also, and WHO training and materials. So our first is a assessment. Our counselors and clinical psychologists conduct the assessment, and according to the assessment, we fix in the different type of activities and treatment. And after the assessment is a medically assisted detoxification we follow, not cold turkey and other approach. We are not following the, as per the physician recommendation, psychiatric recommendation, they are getting the medication service. We have psychosocial program to reduce the relapses and other comorbidities like mental health, and also the co-occurring disorder like HIV, hepatitis B, tuberculosis, etc. And we are providing counseling and psychotherapy through our trained counselors and psychotherapists, and there are some group of psychotherapists working with our organization. We have a family program, and periodically we organize family meeting as per the need of the family. Our counselor providing the couple counseling and family counseling also, because the family intervention is very important considering the Bangladesh context, because family members are not aware of this, of the treatment facilities and also treatment approaches. And we have aftercare services and follow-up services. We formed two self-help group, recovery self-help group. One for the females and one for the males. And I would like to also mention the Dhaka Asne Mission is a running on female center. Is a 40-bedded female center in Dhaka and 3 male center. The campus is different. And we have a mental health services inside the centers, and we have also the OPD, outpatient services. Anyone can take outpatient counseling and services from our organization. And through vocational training and job placement, we are providing rehabilitation services to the patient and also the family members. And why we are telling we are the different than other organizations in Bangladesh. At present, more than 350 licensed drug treatment center in Bangladesh, and also some public government treatment center running in Bangladesh. Our residential facilities is our own campus, and due to considering the duration, we have fixed up the services in the centers. And our preliminary services, residential services for the 6 months for the male and 3 months for the females, because due to considering the social stigma and considering the socio-economic context of Bangladesh, we reduce the residential service for the female SUD. But for the male, the 6-month residential services we are providing. Patients and other family members are encouraged to actively participate in the treatment process. We try to engage them from the beginning to the end of the date. And our physician and psychiatrist consultation is provided throughout the treatment process. It's not a single event. Our psychiatrists visit our patient centers, and he in the COVID situation, our psychiatrists through telemedicine providing the services, and physician physically provided the services in our centers. And DAM is following the treatment approach, the appropriate to the individual's age, sex, ethnicity, and culture. Because Dhaka Asne Mission is a humanitarian organization, so we take care of the whole population of the country, our service. So we've tried to establish our different center, different facilities for the considering the economic and cultural is and other approaches considering the need. And marginalized people and poor patient, they are getting 30% discount from our fixed price. And medical screening, from beginning, we conduct medical screening along with the dope test and also HIV testing. Those who are interested to conduct HTC services, HIV testing services, And if they're motivated to conduct the testing, we have inside facilities to conduct HIV testing. And we also deal with the HIV patient in our center, considering the confidentiality and other need of the physical need of the HIV patient. Established recovery support group, earlier I mentioned, for aftercare services. And our all centers and working environment is non-smoking environment. We are not providing any smoking and cigarette to the patients for male and the female. And this is the unique in Bangladesh, and we are practicing very strictly. Gender responsive treatment for the women substance use disorder, because women's physical need is different than male. So in our center, the gynecologist and other physician is working with the female SUD. After the completion of the treatment, addiction professional offer counseling and other services as follows up those continuing the support. If they need more support, they can take services from our OPD, and also they increase their duration of the treatment in our center, residential services. Harm-free environment facilities, such as we have the library in the center, gym, television, indoor and outdoor games, and cultural event. We engage patient in different cultural event because they feel the good when they engage in the center, because our treatment duration is long. So we need to give them some breathing space. So we organize outdoor event and also indoor event for engaging them effectively in our treatment services. Religious and spiritual activities as always given priority as per the religious belief. If Hindus want to pray, they can. If Christian wants to pray, and Muslim also, they have a separate space and separate facilities for the prayer and religious practice. National and International Day, along with the religious and cultural event, celebrate the International Day in our center, and like World International Recovery Day, HIV, World HIV Day, Tobacco Free Day, International Drug Free Day, we observe in our center. Also, national days we observe. Dhaka Asne Mission activities has been recognized by the several national and international awards. And field of the prevention and treatment, we receive many awards from the government and also WHO and other international organization. And Dhaka Asne Mission get highest level of the national award, we call Independence Award from the government of the Bangladesh, is for the social services in Bangladesh. We just showing a picture. Last month, our Home Minister handed over vocational equipment to the released prisoner. They get vocational training inside the prison. DAM is providing treatment, vocational training inside the prison. After release, we are providing the vocational equipment for their rehabilitation in the society. And this one funded by British government through GIZ. In the COVID situation, we faced a lot of challenges.
Sorry to interrupt. We have just one more minute, Mr.
Okay, I'm going quick. In the COVID situation, we faced a lot of challenges, but we conducted training to our network members and also our staff for managing the COVID situation. And we provided personal protective equipment to our staffs and also our network member free of cost. And DAM organized online training to the prison directorate and other government official, mental health and other training provided. And we have developed some operational guideline how to manage the drug treatment center during the COVID-19 and also screening tools in the treatment centers. And just effectiveness of our treatment, we conduct research and study periodically. This is our task. And we have seen our success rate is a 45 to 60%. It's depend on the time and duration of the after the treatment services. And also treatment reduce the drug use and also crime, and treatment increase the employment and productivity in his life. And challenges, lack of appropriate national law. We are still under process reviewing the law. Lack of qualified and skilled staff, and also the psychiatrist and psychologist. Lack of individual family members, involvement of the family members. Family members, the awareness is very low in Bangladesh. They don't want to involve in this process, but we try to involve them. Lack of funding from treatment marginalized patient for treatment and rehabilitation services, and social stigma is a big issue in Bangladesh. And collaboration at present, Dhaka Asli Mission education provider of the Colombo Plan for UTC and children curriculum. DAM member of Vienna NGO Committee on Narcotics Drugs and World Federation Against Drugs, and also Federation of Therapeutic Community in Asia. This is my small presentation. Thank you very much for hearing me and giving me the opportunity. Thank you.
Thank you very much, Iqbal. The pleasure is ours. We have one question for you here before we move on to the next speaker, and it's from Dr. Ulhas Kolatkar, and my apologies for mispronunciation. This person is asking, are NGOs like the Rotary involved, and if so, in which way?
Thank you. It's a good question. Basically, you know, the Lions Club and Rotary, they have every year they called one great social cause. We have seen Lions Club of Bangladesh. Sometimes they organize drug prevention event. I am also Lion and past president of a club, and also I am the member of the district governor committee. So the Lions Club also giving us little bit funding for our organizing some community-based event, awareness program, and also a little bit give for the patients sometimes. But we try to encourage them to involve in our program, but not 100%. They have so many calls and so many things they are working.
Thank you very much, Iqbal, and thank you for your presentation. Hopefully we'll have time at the end to have a few more questions.
Thank you.
Thank you. Our next speaker is Professor Jing Li. She is the Vice President of China Association for the Prevention and Treatment of Drug Dependence. She's also the Vice Chairman of Professional Addiction Medicine Committee of Psychiatric Branch of Chinese Medical Association, and the editorial board member of the British journal Addiction, to name a few of her many accomplishments. We're happy to have you with us today, and welcome so much, Professor Jing. We will have to unmute you. We can't hear you yet. If you can unmute yourself. It should be in the bottom left corner.
Yeah, do you hear my voice?
We hear you perfectly. Thank you.
Okay. Hello, everyone. Good afternoon. It's my great pleasure here to give presentation of the situation of drug use and rehabilitation work in Chinese mainland. I am Li Jing from the Chinese Association of Drug Abuse Prevention and Treatment. I am the Vice President. Today, I'll have three parts of this presentation. First is the situation of drug use in Chinese mainland. So in China, the situation of drug use is about 4,070,000 registered drug users, and about 2.1 per thousand of the population aged from 16 to 35. And compared to the rest of the world, it's about one per 226. In Chinese mainland, the illegal drugs include marijuana. The number of all users is larger than that of the registered ones. Many other countries used epidemiological survey to estimate the real number of drug use. However, in China, we use the registration to estimate. Our data are more reliable as our data refer to the detection of the public security organization. Additionally, the government conducts a full-scale screen at least once a year to detect those unregistered ones. In my opinion, we implement the strictest method to obtain the prevalence of drug use. The situation of drug use in Chinese mainland, the most population one is ice. We can see this. The means is about 55.1% of all the illegal drugs, and the distribution of the age of users of the teenager to young adult half to half to the adults who about 35 years old, and the total is declined. Prevalence fell down about 10.6% from 2080 to 2019. The community has become the main battlefield of drug control. About 69.2% of the registered users accepted treatment in community. Distribution of the location of use in community increased. And the large amount and rapid emergence of new types of drugs have listed 431 drugs and the whole class of fentanyl listed substance. Continually emergence of the new type of drugs. The new type of drugs, diverse type and rapid emergence. In China, they disguise as something else, such as food, as cigarette, as milky teas and chocolate, and also substitution of listed drugs, such as fluamine. That is the improved ketamine powder, and also some new mixtures, such as containing lysergic acid, diacetyl acid as step, and also some smarter capsule and the capsule zero capsule, G-sport, and also zero liquid. And also the new available psychoactive substance were used as third generation drugs such as synthetic cannabinoid natasha. And also, according to a report from the National Drug Laboratory, about 41 new psychoactive substances were detected in the past years. And also among them, 5 were newly discovered. Second of my presentation is the work of Chinese Association of Drug Abuse Prevention and Treatment in recent years. In China, the hierarchy of drug control network in Chinese is based on legislation, administration, and justice. And the Central National Narcotic Control Bureau is the keynote of the network. And my position in the network is as I am a doctor and a professor in West China Hospital and also the vice president of non-profit organization, the Chinese Association of Drug Abuse Prevention and Treatment. And also my responsibility is a clinical and a professor majority in mental health and a researcher focused on addiction and related problems. And also preside and participate in the work of CADAPT. Let me introduce some main features of this association. It's a non-profit social organization provided as a platform of the member of anti-drug society to continue and exchange their experience and also spread the necessary knowledge to the general community, and also plays the role of an academic leader by actively supporting the completion and the publication of professional books related to anti-drug affairs, and also coordinating researchers to provide the basis for the formulation of laws, regulations, and guidelines in Chinese mainland. Be a regulatory organization aiming to improve the professional performance of staff relative to anti-drug affairs, and also cultivate and establish the team of leaders and experts to engage in the clinical, educational, justice, knowledge space, spreading aspect related to anti-drug affairs. The main achievements of CADAPT in recent years. First, the experts of this association have led the writing of a large number of professional publications, which has laid a solid foundation of improving the performance of practitioners. These publications include books, journals, guidelines of diagnosis and treatment, and also anti-drug brochures for the general community, practical guidelines, and also theory of participants of addiction medicine, introduce the theory and practice of psychological counseling on addiction problems, and also guidelines, experts consensus on the clinical use of benzodiazepines, and also clinical disorders related to opium use, and guidelines for clinical diagnosis and treatment of alcohol use related disorders, and guidelines for clinical diagnosis and treatment of disorders and related to amphetamine type stimulants, and guiding principles and clinical diagnosis and treatment of amphetamine dependence, and so on. And also anti-drug education guideline to pure blossom of use. This is the cover of our books and publications. Oh, I'm sorry. What's this? Yeah, and all these guidelines is publication by the government. For example, by the National Healthy Community, and also Public Health and realistic health. And in recent years, we established a project supported by the Ministry of Finance and the Ministry of Civil Affairs. They cut out the Drug Rehabilitation You and Me, Voluntary Drug Rehabilitation Assistance Project. The project coordinates the medical, physiological, and legal professional resources to provide medical diagnosis, treatment, physiological intervention, legal consultation and assistance, and peer education service to drug addicts in compulsory rehabilitation centers, and directly helped up to nearly 2,000 people, and explored to establish a complete drug rehabilitation assistance system, and improve the ability of drug addicts and their families to prevent relapse, and also improved emotional management and stress resistance, and also reduce the relapse of drug rehabilitation personnel after returning to society. The effects is then included into the in-house drug rehabilitation actionary system and extended to rehabilitation work of community drug rehabilitation community. Finally, of my speech is our work on the COVID-19 pandemic duration. The work of our association under the pandemic, reformed and the workflow of the association consisted of offline training meetings and on-site activities, etc., and active through the network platform, coordinate and organize the domination of anti-pandemic material for Wuhan community, and performed specific works for the prevention and control of drug abuse and the pandemic. For the staff related to anti-drug affairs, released expert concerns on prevention and control substance use and addiction during the outbreak of novel coronavirus pneumonia in March 2020. Investigated, served, and scripted the recommendation, expanded the prescription period for anesthetic and psychoactive drug under COVID-19 pandemic, which has been implemented by the National Health Community of People's Republic of China, then reversed the guideline principles for addiction treatment. For the general community, we launched a series of publications on addiction prevention, and also adjusted the workflow timing after reopening in the second half of 2020. In the second half of the year, training and annual academy conference were organized as scheduled with the support of all branches and members of the association.
Very sorry to interrupt, just the 1 minute mark here.
Okay. This is other specific works. And also the specific works in their spread necessary knowledge to the general community. Some some micro videos and some. It was aimed to establish a national awareness of refuse drug and prevent drug and create a good social atmosphere. And also, the National Symposium of Drug Abuse Prevention on the 19th Academic Conference of Chinese Association for the Prevention and Control of Drug Abuse was successfully held from November 5th to 6th, 2020. Yeah, the influence of COVID-19 pandemic on my own work has some influence. My regular study of brain functional mechanism underlying substance use disorder is suspended, and also heavier clinical work. Okay, that's my presentation. Thank you all.
Thank you very much for this presentation. It was great to hear from you, Professor, and about the situation in China as well. Thank you. We will move on to the next presenter right away. We don't have any specific questions to you at this moment, but people or participants are welcome to write in the chat. Thank you so much, Jingli, for being with us today.
Thank you.
Thank you. Our next speaker is Mr. Abdul Karim. He is the Executive Director of the Singapore Anti-Narcotics Association. In his previous role as Deputy Director in the Rehabilitation and Reintegration Division at the SPS, Mr. Abdul made contributions in the areas of mobilizing community support for offenders, rehabilitation, and reintegration. Welcome, Mr. Abdul. We are very pleased to have you with us today.
Thank you, Regina. Thank you to WFAD and IFNGO for giving SANA this opportunity to share on our work. Distinguished guests, ladies and gentlemen, good afternoon. Is in Singapore, it's in the afternoon. I'm not sure what's the day is at your place. Singapore Anti-Narcotic Association, or in short, SANA, was formed way back as an NGO in 1972. And apart from preventive drug education and our work in local and international advocacy, our core focus is to assist and support people in recovery from drug addiction, so as to help them lead a full new life of meaning and purpose, right? We are aware that it takes a village to fight drugs, and of course we mobilize and work with the community such as schools, youth groups, grassroots, and the families and many other corporate partners to work towards our vision of a drug-free society. My sharing today will cover the following areas: a quick overview of Singapore's drug situation and demographics, a bit of recovery, what it means, and how SANA incorporates the recovery efforts in our case management and counseling framework to help our clients work towards a drug-free lifestyle. And I will also share two of our key initiatives. One is the family program. How do we implement this for our clients and the families? And the second one is the Peer Leaders Development Program. This is a peer support recovery program where we mobilize the peers to contribute to our clients in their recovery journey. Let us take a look at the key drug statistics for Singapore. Singapore's population stood approximately about 5.6 million in 2020, and out of which our resident population is 4 million. Right, the number of drug abusers, as you can see on your right, it fell about 15%. Okay, we had about a total of 3,014 of them were detained for treatment and rehabilitation in 2020, compared to 3,526 in 2019. But probably we know that this could also be likely due to the reduced movement of travelers across Singapore's borders, which would have impacted both the drug supply and demand. But however, the proportion of new drug abusers, which you can see on the left, new drug abusers remain high, as at 38% of all abusers arrested. A total of 1,143 in 2020 as compared to 1,460 in 2019, right? And of this, 703 or 62% of them were below 30 years old, and this is something of concern for us, the increasing number of younger drug abusers, right? And of all, looking at the age profile of all the drug abusers detained for treatment and rehabilitation, 1,232 of them were under 30 years old, right? You look at the graph on the left, below 30 years old, 1,232 of them. And this form about 41% of the total number arrested in 2020, right? And of course, those in the 20 to 29 age group continue to form the largest group, with about 932 of them detained for compulsory treatment and rehabilitation, right? Looking on your extreme right, you will see a 40% increase in the number of drug abusers in the 60 and above age group, 232 in 2020 as compared to 203 in 2019. Right. In terms of the types of drugs abuse, mirrors what Karen Peters shared earlier. Meth, the number one choice of drugs, and the most three commonly used drugs is meth, new psychoactive substances, and cannabis, and this by the new drug abusers who were detained in 2020. But again, just to share also what Karen Peters mentioned, that there is, of course, evidence to suggest that drug abusers have a higher tendency to engage in criminal behavior and crime, and that drug consumption and trafficking do fuel other crimes as well. In our own prison population, we find that quite a number of them, more than 70% of them, are in there for drug-related offenses, right? In terms of, for SANA, our guiding principles is that we know recovery means is total abstinence from all types of illicit drugs and alcohol altogether. We recognize that there are many pathways to drug addiction recovery and may vary from one individual to another, right? We also agree with what Asha Ashraf shared, that recovery is just not abstinence, but it has to be holistic, and it has to focus on the varying needs of each individual, and on their mental health, spirituality, family support, pro-social networks, and so on. In SANA, our community-based case management services, we provide casework and counseling to our clients to support them in their recovery journey while they are with us over a period of 6 months to a year. Right? This is an individualized, tailored approach planned according to the needs of each individual. We have 2 phases. In phase 1, which is known as the stabilization stage, and phase 2 as a preparation stage to complete the program. In phase 1, we work on their motivation and readiness to change, as some of you have already mentioned. And this is an important starting point to begin with, right? And we also look at the individual's other domains, the social and human capital, to ensure that the basic needs such as accommodation, employment, and financial support are well taken care of, and their support network to help the client in his or her recovery. More importantly, that they have, the clients have the necessary coping and problem-solving skills, as well as a well thought through detailed relapse prevention plan. Right, the first phase is important. Equally important, the phase 2 is to just continue to work to strengthen the domains in the different areas, such as like strengthening motivation, familial ties, and support networks before they complete and leave our program. And some of the principles that Karen Peters mentioned are part of our treatment program as well. right? Let me just share two programs that we find that is important for us and has been contributing a great deal in helping the recovery of our clients. Right, we know that family is a strong pillar for a recovering person, and when families understand about addiction and recovery and able to support the clients in their recovery journey, more of them will be successful in recovering from addiction. Right, Sana has introduced the two main branches of family programs. Right, on the left you can see one is called Sanabration. Right, what is this? This includes small scale to medium to large scale events. Okay, small scale event provides clients and families a recreational space to do simple activities that can be recreated at home, such as painting, movie watching, keychain making, and so on. And this is to provide clients and their families a template of core leisure activities which may improve family functioning, right? And this is drawn from the core and balance model of family leisure functioning. The next one is the medium to large scale activities. This is to provide clients and their families opportunities to bond through balanced leisure activities, which may improve family functioning. Again, drawing from the same model, the core and balance model of family leisure functioning that I've mentioned. Right. The next one, the second one is called the FREE, meaning it stands for Families in Recovery, Engage and Empowered. And there are two parts to this. The first part is the psychoeducational talk. This is targeted to shift the focus of the affected family members from their loved ones recovering from addiction to addressing their own needs to better support their loved ones in a sustainable manner, right? And we have built this program based on the stress, strain, coping, and support model, which is a 5-step intervention model that I've listed right below, right? That's the first one. And the second one in the FREE Families in Recovery, Engage and Empowered is what I call the family support group, right? Many of you may have run this support groups in your own programs, right? This is for affected family members who are often coming out from isolation and supporting their loved ones. Again, the similar model, stress, strain, coping, and support model, the 5-step intervention model is used to run these programs, right? And this is the family part of the program. The second one I want to share is the peer recovery support services, right? We call it the peer leadership program. This one complements our case management and counseling. And peers, what are we talking about? We're talking about peers. Peers who are those who have achieved significant progress in recovery and are able to motivate others who are struggling. And we have been engaging peers in many of our recovery programs, and over the last few years, we have formalized the programs where we actively recruited, trained, and deployed peers in many areas to support the recovery of our clients. And we also do regularly gather feedback from their contributions as well as from the clients who have benefited from the peer recovery programs, right? What are the range of activities that we involve peers in our programs? One is for advocacy for people in recovery, right? They're also involved in preventive drug education, educating the public, sharing of testimonies in schools and other public events. The third one is the recovery efforts. They do co-lead recovery groups and where they support the peers' recovery journey. Last but not least is the befriending, right? Where they support an individual by befriending them and encouraging them in their journey. Of course, we may be familiar with the benefits. One is they are credible because they have gone through the same path and are able to inspire hope that one can work towards successful recovery and that change is real and possible, right? And they also become good role models for others to follow suit, that where you can do your part once you are successful in your recovery journey to also give back to society by taking part in community service or doing voluntary work, right? And it also allows them to maintain the connection of the peer support community as a resource to stay grounded, right? The clients get to meet a lot more of them who have been successful, and this provides some form of support for clients who are in their recovery journey. Some of the activities, photographs of our peer leaders who have been involved. They've also been involved in some of our webinars on recovery, and they've come forward to share their testimonies to families, to our clients, as well as to the general public. Right. Some of the feedback from our peer leaders in terms of how they have benefited from their contributions in this area. Some of the feedbacks are here for you to read.
Just one more minute now.
All right, sure. Just the last part, I just want to check about the challenges posed by COVID-19. We, just like anybody else, like we also do face challenges which interrupted our delivery of our programs and services. We moved some of the activities online using the Facebook platform and converted to online psychoeducation through posters and short video segments. Even the support group sessions went online, but one of the challenges that we had was where family members need to share, especially if the recovery person is staying in the same household, pose some difficulties for them, right? But with this COVID-19 experience moving forward, it has created some urgent need for us to relook at how we engage our clients. Post-COVID, we need to really think about digital inclusion so that our clients can access many of the programs and services, not only created by us as well by the other government agencies and so on, and not to be further disadvantaged. So digital inclusion would mean that we need to find ways for them to have access to and use the information and communication technologies. And some of the areas we need to look at is affordability, its relevance. Whatever programs we create, it must meet the needs of the client. The client must also have access to digital literacy training, quality technical support, and more importantly, in our policies, this requires intentional strategies and commitment of resources to reduce and eliminate the institutional and structural barriers to access and use of technology for our clients. And on that note, let me thank you.
Thank you very, very much. It was great to listen to your presentation and also seeing the challenges that you faced during COVID and how you managed to move beyond those. And these last words in moving forward is something I believe that we can all take away with us from today. So thank you very much for being here. We are a little bit short on time, but I want to give our final speaker all the time that he needs to present. So I will save the questions and answers for the end of the session, and I hope you can all spare another 10 minutes at the end, and we will go through some of the questions and answers. And again, we will make sure to have all of them answered and sent out after the webinar. So last but definitely not least, I would like to welcome Martin Infante. He is the founder and president of Self-Enhancement for Life Foundation. SELF is a therapeutic community approach for the treatment and rehabilitation of substance abuse and other behavioral disorders. We are very pleased to have you here with us today, Martin. And I should say you're from the Philippines, so welcome, the floor is yours.
Okay, thank you, Regina. I hope we still have the time. No? So I'll try to make this really quick. I'd like to also thank the organizers for inviting me for the second time. My privilege to have to be able to participate in this IFNGO and WFAD. No? Okay, I'm going to present 5 key features of our therapeutic community approach. No? So in starting, allow me to introduce my organization, Self-Enhancement for Life Foundation, or SELF. We are a non-profit, non-government organization dedicated to the treatment and rehabilitation of substance abuse and other behavior disorders. SELF has been operating for nearly 3 decades, and we employ the therapeutic community approach. A few demographics: 75% of our population are male, 25% are female. Our cases are usually 70% substance abusers and 30% behavioral cases. Our age range is from 15 years old to 65 years old. No? When we started out in 1992, our program was based on the traditional structure and practices that we inherited from other TCs that preceded us. They were rigid and coercive and were run mostly by graduates of the program. They managed residents the way they had been treated once before, and they did not have a clear grasp of the rationale behind the practices. What was the guiding philosophy? You need to be an addict to understand addiction. Although there is some truth to this, the problem was they were not able to address the comorbidities of their clientele. There was a fear that engaging professionals such as psychiatrists, psychologists, social workers, etc., would make the TC program lose its essence. We too in self went this way for the first few years. No?
Very sorry to interrupt. We don't see your slides. Apologies for interrupting, Martin.
Slides will be coming. Yeah. You got it? Yes, we got it. Well, thanks to the dynamism of our organization, we were committed to reviewing our methods and practices in order to give the best for those placed in our care. Through international conferences and training workshops, we were able to get an in-depth knowledge of the principles that govern the TC. We were able to understand, essentially, why we do what we do. We immediately modified our structure and reviewed our methods and practices. Throughout the process, however, we made sure that we preserved the very essence and integrity of the therapeutic community approach. Goals of treatment. For us, addiction is not simply a medical problem that can be addressed with a medical solution. It is more of a relationship problem. Dependency is a brokenness rooted in relationship issues, more often than not in the family. The dependent is only a symptom carrier, indicating that something is not going right in the family. Much like a fever is indicative of a deeper condition. So it is not enough to eliminate the symptom. In fact, in self, we work hard to help our clients find the root cause of their behavior. More often than not, this process takes a longer period of time. We believe in the bio-psychosocial spiritual approach in treatment and rehabilitation. For us, the goal of treatment is the rehabilitation of the whole person and not simply to promote abstinence. It is important to forge a commitment to right living, for only in this way will there be a chance at achieving sobriety over a long term. Thus, the proper approach is to heal those broken relationships. How? By helping the addicted regain the values that they have lost, the values that bind families and communities together. At self, the goal of treatment and rehabilitation is to facilitate the achievement of personal integrity. We feel we have to deliver the client from the have to when they first came in. Of course, they have to because they were arrested. They have to because their family put them there. They have to for this and that reason. We have to deliver them to the need to, which usually is achieved during treatment because of all the peer action and activities that they're able to realize, oh my God, I need this program. But the final destination is the want to, which is usually achieved in higher recovery stages. And maybe not all even get to achieve that stage. No? And we all know that recovery can only be successful when finally the client wants to change. Okay? This is precisely what a TC does. And the core approach is called community as method. That is, people living together and helping each other change behavior, lifestyles, and identities. As Dr. George De Leon, one of the leading researchers of the therapeutic community, says, the community is the method itself. Constant participation, evaluation, feedback, and reinforcement of personal responsibility are core components of daily life. You have a right TC when the individual uses the community to help himself change his own behavior. Now, here are the key features of our self-approach. The first one is the core values. It's important that we note and we share to everyone that we believe in the innate goodness of mankind. Every human being is created under the image likeness of God In practice, when we start to confront residents to modify behavior, we make it clear that we detest the attitude, but never the person. We are a strict yet caring environment. Strict, but never abusive, and caring, but being careful not to become enabling. We uphold 3 governing principles. All our methods and practices have to pass the scrutiny of being respectful, logical, and practical. Respectful. Staff and residents alike must show respect in all interactions. Even when employing behavior-shaping tools, we never degrade the client, no matter the severity of the case. At times, concerns have to be delivered in a loud voice, but that's okay as long as we do not include cursing or name-calling. Let's go to logical. All our practices must have a clear objective and therapeutic value and must hang together with all the other methods and practices. They cannot just be taken alone. And finally, practical, where all teachings must have a clear way of strengthening the client to say no to drugs and be able to survive in the real world. Our second key feature would be our dual approach program or dual program approach. We employ a dual program approach combining the behavior modification of the therapeutic community using its traditional tools of the house with clinical intervention that includes psychiatric management, case management, cognitive behavior therapy, family dialogues, family empowerment, and so on. Here are a few highlights of our program. Graduates of the program may still head various program phases with the oversight of professional staff. So we still give a lot of jobs to successful graduates of the program. All decisions on the client, this is very important. All decisions on the client are made by a transdisciplinary committee. We call it a TDCOM. Never by one person. It's composed of various disciplines and sectors of the community. For example, you have nurses on one side, you have directors, you might have also the safety officer who will be included there, or the cook maybe, or the carpenter who can give insight and observation on the behavior of these residents. Hence, no single staff member may make decisions over the clients. A key feature of the TDCOM is the inclusion of junior residents of the program, of course, those in good standing, who are introduced into the culture and learn how to make judgments on the behavior of their peers. Truly, community as method, as we say. Then there's the 7 checkpoints on the road to recovery. The program is well defined. There are clear milestones to achieve throughout the program. Residents are appraised using behavior indicators and are facilitated more accurately in the succeeding stages. Next is we run a 3-stage program. First of all is treatment, then rehabilitation, then continuing care. In the treatment stage, we developed an induction period, something that was absent in the old school methods of the TC. Before clients are accepted in the program proper, they are made to stay in the evaluation and motivation unit. That's what we call it, EMU. It's basically an induction phase. They are screened to determine their physical, mental, and general fitness to join the program. They are also given a thorough orientation to the TC and motivated to join the program voluntarily. So a lot of MI going on during this stage. So we don't force people to sit in the chair. Those are the old school methods. And they have to end up choosing to join the program. That is key of the induction phase. In the rehabilitation stage, we offer a facilitator training course where participants undergo an intensive process of developing the requisite knowledge, skills, and attitude that will qualify them to support the staff in running the various operations of the facility. As trustees, they assume positions of responsibility that continuously challenge and strengthen their commitment to personal growth and recovery. In the continuing care stage, we go beyond simple abstinence and focus on facilitating the achievement of personal integrity. To this end, We established the Supervised Practicum and Internship Program we call SPIP. And our experience has shown that working alongside our professional staff has enabled these interns to increase their confidence and deepen their appreciation of sobriety. Okay, the third key feature is our manual of operations. Unlike in the old school where everything was just blind obedience, a manual of operations itself is published and made available to every member of the community, that is the residents. No? Essentially, it lists and defines everything that can be done with a resident. Nobody can invent the rule. Also, everything that has been done with a resident is documented. This promotes transparency and prevents abuses that can easily happen when staff, either the programmer or professional, have to make when they are left alone. Such manual of operations is constantly updated through regular internal audits. In our case, every 2 years, Self holds an operations convention we call OPCON, where the entire community of residents and staff convene to review the methods and practices of the program. This democratic process of giving the residents a voice in improving the program provides immense therapeutic value that promotes personal growth and genuine concern for the community. Then we move to our fourth, the behavior shaping tools. Self has maintained most of the traditional behavior shaping tools of the TC. In 2012, however, we incorporated the emotional bank account system, or we call EmoBank, system of Stephen Covey, author of The 7 Habits of Highly Effective People. In the EmoBank concept, residents are monitored for making deposits or withdrawals with one another, thus affecting their EmoBank balance, just like with a bank account. Deposits increase naturally the balance, while withdrawals deplete their emotional bank balance. The emotional bank account has become an important factor for us in determining the progress of residents, and it is a standard reference during transdisciplinary committee or TDCOM deliberations, as I mentioned earlier. I don't know if you can read, I can leave it there for a few seconds, but there are 5 areas: kindness and courtesies, meeting expectations, keeping promises, avoiding duplicity, and making apologies. So you can see for a few seconds, and this has been patterned after Stephen Covey's table, but we made it specific for our rehab center. I don't know if we have the time to show it, so I'll proceed. The final feature of our program is the Family Empowerment Program. Since its inception in 1992, SELF has always involved the families in the program. Through its monthly family association meetings, families are educated about the TC process and experience the healing that it brings. Families must also attend the monthly family therapy sessions, where they discover the realities and dysfunction of codependency. Families are encouraged and empowered to change their own lives by discovering family operating systems that foster unity and growth. So we encourage families to go into their own recovery from codependency. This is very important for us. The Family Empowerment Program is also an invitation to spiritual awakening and renewal, as families are facilitated through their own journey of recovery from codependency. We build lives and restore hope, not only of the addicted individuals, but of their afflicted families as well. For us at SELF, family empowerment has been a fitting response to the insight that addiction springs from unresolved relationship issues. Continuing sobriety and sustained commitment to right living can only be attained when the brokenness is healed. A hallmark to our FAM program is how we teach families about the TC culture. We train them to think like the TC, and at the end, crucial decisions that we make on their loved ones, the residents, during the process of their program are made in conjunction with the families. So we don't go out making decisions. We make sure that the families are on board. They have to sign off on the decisions themselves. Finally, regarding training on the TC, I'd like to say that SELF, together with the Federation of Therapeutic Communities for Asia, or FTCA, which I currently lead, is committed to providing the much needed education and training on the TC approach. Through our recently built International Institute of Therapeutic Communities, or IITC Training Center, we hope to resume this service once the pandemic is over. In the meantime, you can also stay tuned for our online FTCA webinars. In closing, I'd like to say that the TC is very much alive in the Philippines and in Asia. With formal training, we can keep the spirit of this great program vibrant. Thank you very much.
Thank you so very much, Martin, for this fantastic presentation. I myself, and I see a lot of the comments, are very impressed by this emo bank, as well as your organization and presentation at large. So thank you very much for being with us today. And I will just spend some short moments in having two of the questions answered here from the end before we close this session. I will make sure that Mr. Abdul Karim gets a chance to answer the question that was directed towards him, and then we will have a question from Martin as well before finishing. The rest of the answers we will have, or ask our speakers kindly to write answers to us, and we will send them with the thank you email. So thank you again, Martin, and I welcome Mr. Abdul. I have a question for you asking if Sana is a kind of detention facility dedicated to drug abuse? I see you've seen the question, so I'll let you answer.
Yeah, Sana is a community-based organization, and our clients are two groups of clients. One who are mandated, who have once they have completed their compulsory treatment rehabilitation, they're out in the community, and we provide the case management and counseling. And the other group of clients are walk-in clients. They just walk into our center if they need any kind of assistance in terms of recovery support or any kind of other assistance in finding a job, for example. Yeah, so Sana is a community-based organization.
Thank you very much. We have a lot of really, really interesting and great questions here in the Q&A. I don't know, Martin, can you see the Q&A function? And perhaps I can let you decide for yourself which of the questions you'd like to answer. Or would you like me to read one for you?
Wait, which one? What?
You could please read one. We're not entirely sure.
Okay. So we have one, it's in 3 parts. Perhaps you can answer briefly, and then we will, like I said, ask everyone to provide comments in text. It says that, hi, I'm a recovering drug offender myself, managed to keep myself clean for the last 16 years. My questions are, what's the efficiency like for everywhere on rehabilitation? What is being done to curb drug use for youth? And then, is there a way to do rehabilitation efficiently without confrontational methods? And he adds that he wasn't a drug addict and he's always in recovering process.
Yeah, I'm sure the answer has to be yes for the third one. No? Is there a way efficiently without confrontational methods? Absolutely. But at the end of the day, see, for 30 years that I've been doing this, by the way, where is it now? Don't scroll it.
Yeah.
Muhammad Ridwan. I'm also a recovering individual, for your information. I've been sober for 31 years. So I had to go through this process once upon a time, and I just dedicated myself to fixing some things here and there in the therapeutic community. I still love the approach, but I'm sure that people can recover through other methods. There are the short programs. If the short program cannot work, you can always go to the TC. So congratulations on your 16 years.
Indeed, congratulations. All right, so I see that Asia had some questions in the beginning, so I will ask her quickly to chime in here on the questions, and then we can see if we have some more comments from you before we finish. I don't see you, Asia. Are you still with us? No, it doesn't seem like she's still with us. All right, so just to save time, I don't want to go too much over time. Oh, now I see you, Asia. Please go ahead, and you have to unmute. And just 1 minute.
Yes, just 1 minute. There were a question related to evidence-based family approaches. The evidence-based family approaches we use are behavior couple therapy, multi-systematic therapy, multi-dimensional family therapy, and the brief strategic family therapy. These are the evidence-based family therapy used. Second question was that if the female, they get services from the professional, female drug abuse is like underreported, understudied, and they have a very few services like options for the treatment. But if they get an opportunity to for the treatment, family therapy is important parts and parcel of the rehabilitation process. Definitely, it cannot be completed without the involvement of the family. And the third question was like the role of the government. The government is basically working on 3 areas. That is supply reduction, it's like a kind of a harm reduction, and international cooperation. They have a drug abuse control master plan. They are in collaboration with the UNODC. They are hosting training for addiction professionals, and they are also working on the international cooperation. And lastly, there was a young person in recovery. My hands to him, like he's doing great. And he said like how the efficacy of rehabilitation centers can be increased. Definitely where there is like if there are evidence-based practices, there are trained professionals, and they are involving, there is case management and the family therapy. Definitely services of the rehabilitation centers, they are improved. And for the young people, I would just say that we need to work more on prevention. So there is no, the number is reduced. And if there, or early intervention, prevention and early intervention. And thirdly, if we are not able to be very successful in the prevention and early intervention, then the last is like treatment should be really readily available for the young people. So I think these were the questions. They were, if there is any question left, I can write and answer in the email. I asked for 1 minute.
Thank you very much, Asia. And that's a great job in fitting so many answers into a very short time. So I applaud you for that. And thank you. And thank you again to all of these fantastic speakers. I will try to finish off and just by stating that it's been a fantastic webinar, and it shows great best practice interventions from various countries in Asia. And I can safely say that we would need more time, so we will aim to provide yet another webinar and continue this series on best practices of treatment and recovery interventions in the Asian region. I thank you everyone for your discussions. And like we said in the beginning, the recording will be made available and a summary will be published on the WFAD and IFNGO websites. You can follow us on social media or become members of both WFAD and IFNGO, and you'll hear more about this and join our global network in promoting treatment and recovery and prevention, of course. So thank you so much to our co-organizers, IFNGO. Thank you to our prominent speakers. And thank you very much to our participants for being with us this afternoon. I hope to see you all again very soon.
Thank you. Thank you.
Thank you. Thank you, Rosina.
Thank you.
Stay safe, stay well. Bye.
Bye. Thank you.
Thank you.
Thank you very much, everybody.
Bye.
Thank you.